our last speaker of this session, I'd like to introduce is Dr. Jon Ritter. He is a professor of pathology and immunology here at Washington University. He's the section head of cardiothoracic pathology, the interim section head of gastrointestinal pathology, and the director of the surgical pathology fellowship. And he'll be discussing the pathologic diagnosis of amyloidosis and the importance of subtyping.
Well, thank you for that nice introduction. And it's interesting. So I'll be here at the end of the process today. Although thinking about the way that that this disease works, oftentimes it's the pathologists who are there near the beginning because a lot of these nifty things just won't happen if we don't make the appropriate diagnosis. And I think the title of this overall seminar, being the hidden disease, I think, kind of hits home for me because, that's, again, it's incumbent on us to diagnose it. Sometimes the pathology findings are very obvious, but there are other times when this can be a significantly challenging diagnosis. So I just have one disclosure, that is I'm doing a scanner validation, but that doesn't really have anything to do with today's topic. And unfortunately, I have no other financial conflicts that I need to disclose. And
can you go ahead and share your screen? I don't think we see your slideshow.
Oh, okay.
I'm seeing it.
It says on screen sharing.
Yeah, I was seeing it. You're all good.
That's okay. Just on me then.
Yeah, Josh is lost. So.
All right. And so hopefully people will develop a better understanding of the process of how we diagnose amyloid and the ways that we can further subcharacterize it. This finding of amyloid goes back. Was described by a pathologist almost 200 years ago. It was Virchow in the 1800s. He thought it was a starch, and so hence it was the amyloid. And now we know that in fact this is a number of proteins that share these common features, which is this tendency to aggregate into these thin fibrils and then to form these secondary beta pleated sheets. Those then are insoluble and they deposit in extracellular spaces and they interfere with the cellular function and structure. And that because of those chemical properties, that's also what allows it to stain with certain dyes that we can use in pathology to make these diagnoses. And we know now that there are more than 30 amyloid related proteins, from beta amyloid associated with Alzheimer's to light chain amyloidosis to amyloid A protein or transthyretin, which depending on whether it's mutated or not, it could be senile or hereditary amyloidosis, and so on. So that number of that list of potential proteins keeps growing. So there have been ways over time to characterize amyloid. From back when I was a med student or resident, this was sort of an obscure disease, and we diagnosed it, and that was kind of the end of things. So. But we talk about primary amyloid, which is another name for light chain amyloid or AL amyloid. It's the most common type. And, of course, we associate this with plasma cell neoplasms or hematologic neoplasms, and tends to involve the kidney, heart, and, other organs. Secondary was a name for kind of the other type of amyloid that was commonly the amyloid AA type, and was seen with chronic inflammation or chronic infections, and is related to the increased serum production of these amyloid A proteins in those inflammatory states. Again, tends to involve the kidney, the liver, the spleen, less likely the heart. And we commonly see senile amyloid as this wild type ATR, which is oftentimes involving the heart. Likewise, the hereditary form of ATR, again, tends to involve the heart as well. And then we can talk about neoplastic as any type of amyloid that is related to a neoplasm. That's commonly myeloma and AL, but we also see amyloid associated with, for example, medullary thyroid carcinoma from calcitonin, or carcinoid tumors can produce neuropeptides and things that can form amyloid. So how do we look at biopsies in pathology? Of course, we get a biopsy. Virtually 100% of biopsies to us come in formaldehyde. We embed that material into a paraffin block and then cut thin sections, mount them on glass slides, and do H&E stains. And then that's the starting point for virtually every pathology specimen that comes through the laboratory. And so from that, we can see H&E examples of amyloid. For example, here's a cardiac case. We see this amorphous eosinophilic looking material on H&E stains. It tends to compress the myocytes like here or here. The ones that are left here then can get hypertrophic. And, this screams amyloid. It doesn't look like fibrosis. It looks like amyloid. In the kidney, we can see a variety of deposits. This case has these eosinophilic glomerular deposits. In the liver, amyloid tends to deposit along these sinusoids and it compresses the cells. You can see these poor little hepatocytes being compressed by these amyloid deposits. Amyloid produces this eosinophilic material. It has this amorphous or sort of non-structured appearance, and it doesn't have cells, unlike most examples of fibrosis where there are fibroblasts. It's almost acellular in its nature. So these H&E appearances would scream amyloid to us. Here's a nice liver biopsy that showed amyloid deposition in a vessel wall, which is another common place that amyloid will deposit. And those different patterns of organ involvement can also give some suggestion about the subtypes. For example, in the lung, when we see diffuse septal amyloid, which I'll illustrate in a minute here, it's almost always due to systemic AL amyloid. On the other hand, if we see nodular amyloidosis, it's associated with many different types of amyloid. And as we just heard, in the kidney, again, there are different patterns of different compartments being involved based on the type of amyloid. Again, there's really too much overlap in most of these to really be very useful in terms of saying what exactly is the subtype of amyloid that's present. As I said, here's an example of diffuse septal amyloidosis. You can see the alveolar septae in the lung, and they have these nodular deposits along the septum, and this is highly likely to be AL. On the other hand, here's a section of one of these nodular pulmonary amyloidomas, which are just large amorphous collections of amyloid, and that could be a variety of things, and they're often associated with AA from infection, or they could be AL as well. So again, these are suggestive, but they don't really allow us a great way to actually classify these. Now, as mentioned, of course, by many speakers already, and this will be by way of review, the nice thing is we can take those paraffin blocks, and if we suspect that it's amyloid, we can do a Congo Red on that paraffin embedded block material. You can get about 1,000 glass slides out of one paraffin biopsy block. So we have plenty of material to do those Congo Red stains. It's red on just light microscope, on regular light microscopy. You can see this pink eosinophilic material, again, mostly deposited in glomeruli here. And if you polarize that, it produces this nice so-called apple green birefringence. Now, the thing about the Congo Red stain is, you have to order it. So this is where pathologists, I think, now really have to kind of up our game, because yes, this is highly suggestive of amyloid, but many cases are much more subtle, and so we need to be aware of particularly biopsies that could look vaguely normal, and if somebody says, hey, this patient's having GI symptoms or renal problems or whatever, and we don't see another thing, we need to have amyloid somewhere in the back of our head so that we say, hey, maybe I should get a Congo Red. That vessel looks a little funny, or there's some eosinophilic-like material there. So, we need to, because this is only going to work if we order the stains. And this is also where the clinicians can be a great help to us, providing us some history that maybe they suspect amyloid, because, of the patient's clinical presentation, is tremendously helpful in terms of sort of priming us to really look for it in more subtle cases. There are some other standard special stains, again, that we like to use. I oftentimes will get a thioflavin stain if I suspect that maybe there's a little bit of amyloid that's not immediately obvious. Also, our neuropathologists like to use this for nerve biopsies because nerves tend to non-specifically bind the Congo red, and it makes background staining. And you can easily read this. It produces autofluorescence, and you just read it under a fluorescent microscope, and it will highlight very small amounts of amyloid. Crystal violet is another standard stain people may use. And the trichrome stain is sometimes helpful if you have a heart biopsy and you see some interstitial material, and the Congo red is negative, but this trichrome stain produces this nice dark blue color. You can say, well, it's probably fibrosis in the setting of an infarct, or somebody with just cardiomyopathy and some fibrosis or something. And again, remember that none of these stains are going to help you distinguish between the types of amyloid. And so, why is it important to have the subtypes? As we've heard, all during the day here today, that, they differ in their history and their outcome and their treatment now as more and more, specific drugs are identified for specific types of this process. So, and of course, the hereditary forms also have implications for other relatives. So, we do immunofluorescence on kidneys, sometimes on heart biopsies. And this material has to come in Michelle's, and then we freeze it, and we take frozen section slides, and we can stain them for light chain. We stain them for lambda. Here's a nice lambda positive case, and kappa again. Lambda is more amyloidogenic, and so this can be helpful. There are some pros and cons about immunofluorescence. It's a good way to diagnose AL amyloid. But not other types, obviously. And some groups advocated a panel of 10 or 15 of these different antibodies to try to classify these more unusual subtypes. Unfortunately, as that list has grown, this isn't really very practical. And so, tissue has to be sent for IF analysis, and that doesn't get examined for H&E sections or the Congo red stains. So if it's focal in the organ, that could be missed, based on material that got sent for IF only. And we only routinely really get these for kidney biopsies, sometimes for heart biopsies if amyloid is suspected. So, it's just not available for most types. Again, there are some people who say you can do immunofluorescence on paraffin sections. In practical terms, we really can't do that. It doesn't work very well. So we're limited in our ability to do this if it comes in formalin to start out with. Electron microscopy, as we've heard, again, requires typically submission of tissue and glutaraldehyde for special processing. It's really only used in renal biopsies at this point. It's expensive, it's labor intensive. People don't really like doing it very much anymore. But it does produce these nice, you can see these nice electron dense deposits, and then these kind of characteristic 7 to 12 nanometer non-branching fibrils on EM. So this would be diagnostic of amyloid. And again, in the kidney biopsy setting where immunofluorescence and electron microscopy is routinely done, this is another way that amyloid can be diagnosed. Again, we like to use mass spectrometry to look at these material, and that can be done out of the paraffin blocks, which makes it incredibly useful. So, we get tissue from the paraffin block, we get a Congo red stain, it localizes the amyloid. That tissue then is laser micro dissected out, that Congo red positive areas, and then mass spectrometry is run on that, and they sort these proteins out by their mass and electrical charge, and we can get highly specific information out of that. Again, so what are the advantages of this is that we can do this on routine tissue. We don't have to know the diagnosis before the diagnosis, and if we see unexpected amyloid, we can turn to this to really get a highly specific type. It's actually relatively inexpensive, and it provides very, specific information. They can typically tell mutated ATTR from wild type ATTR, for example. People, it is a bit of a black box, that goes off and an answer comes back and you have to sort of trust that. I think only Mayo is doing this in any significant volume. So you have to send off material to them. It's not being done locally. So that, sometimes that's a bit of a problem, but we like to always confirm our diagnoses and subtyping with this testing because it's relatively rapid, inexpensive, and seems to be quite specific. So, this would be the workflow that we would use is we get H&E sections. If we suspect amyloid either by H&E or clinical suspicion, we're going to start with a Congo Red. If that's negative, it's probably not amyloid. If it's positive and we have tissue for IF, if it's a kidney or a heart biopsy, we'll perform that immunofluorescence. If that's positive, it's amyloid, AL probably. And then, oftentimes, to be perfectly frank, we still like to confirm this by doing mass spec, and we're going to do it if it's negative. Again, it does raise the question about how useful this really is, but it's another step that we can take. If we don't have tissue for IF, we're going to go right from that Congo Red to mass spec, and this should give us a nice amyloid subtype. And so I think that's what we have. Again, I would sum up my talk by saying that it's important that the pathologists are aware of this, that they're thinking about this for unusual cases, and that they're also on top of the methods that we can now use to further subtype this. And because if we don't make this diagnosis, we're not going, the therapy and other things aren't going anywhere. And thank you.
All right. Well, thank you very much, Dr. Ritter, for that deep discussion on pathology. And yes, we send lots of specimens to you to help us with the diagnosis very early on.
You guys are fantastic to work with. We appreciate the material.